session today. So just want to announce that there's remote captioning for those joining online, and hope, or someone else I think is going to put the link in the box there. And then the meeting is being recorded for the DMAS website, so please keep that in mind. Also, the sound today is working best with the table microphone. So if you're in the room and speaking, please use the mic so folks online can hear you. And the first order of business is just roll call. We can do the next slide.
Next slide, please.
There we go. Irma Blackwell, Susan Brown,
Present.
Kelly Cannon,
Here.
Sarah Cariano here, Martha Crosby, Heidi Dix,
Here.
Shelby Gonzalez.
Here.
Next slide. Alexandra Javna.
Here.
Estella Obi-Tabat.
Here.
Jennifer McDonald.
Here.
Emily King.
Here.
Who's a sub for Freddie today from Commonwealth Institute. Michael Muse. Emily Roller.
Here.
Hannah Schweitzer.
I think Hannah is joining remotely.
I think I heard, did I hear here from online?
Yes, here.
Yeah. Nathan Webb. And that is it. So the first CHIPAC business is reviewing and approving the minutes from our June 1 meeting. So they're in the agenda packet. If folks could take a moment and review them, and then we would need a motion and a second to vote to adopt or change them in any manner.
Motion to adopt. Motion to adopt minutes.
Anyone want a second? All those in favor, please say aye.
Aye.
Anyone opposed, say no. Great. Minutes have been approved. Next is just reviewing and approving dates for the 2024 meeting schedule. And Hope, I think you we're going to intro that.
Yeah, so we have the copy of the meeting schedule is in the packet that you picked up at your door or got in your email. And there's one, it's up on the slide here. We like to kind of preview the schedule for folks so that if you want to flag any dates that you know of a major conflict that's going to affect a lot of people in the children's health space, you can let us know about that and we could adjust accordingly. But this is the schedule that the executive subcommittee met and approved. It's usually the first Thursday of each month, month in that quarter. I think there is one exception in December. We chose to have it on the 12th, so it would be a little further away from the Thanksgiving holiday. And similar for the executive subcommittee meetings, I think that there's one meeting that's during session and we might have bumped that to a different Friday than the usual Friday. So just take a look at that. If any dates jump out of you as being a problem, we'd love to know that. And otherwise, we would just need a motion to. There's also, you'll see noted, the all virtual meetings are in blue there. So we have every other meeting is a virtual meeting.
Just as a reminder that, the in-person meetings are the exceptions to attend virtually, and we do always accept subs so that we could still have quorum in person as well. So if these dates seem to work for now, at least, we'll just need a motion and a second to vote on them.
Second.
All right, all those in favor of adopting this calendar, please say aye. Anyone opposed, please say nay. Great, our dates have been approved. The next are some membership updates. So we have a few more this meeting than normal. So first, Jeff Lenardi, who was the JCHC representative, and JCH, the Joint Commission on Healthcare, is a mandated member of this committee, has now moved over to DMAS to be the Chief Deputy Director here. So I believe while they're still working out finding a new lead at JCHC, Estella will be the stand-in for the next little bit. So welcome and thank you for being here and stepping into the position. Ali Farouk has also joined DMAS, so he was from Families Forward and is now here in the policy position, a policy position. And we do not have a replacement for that spot right now, but as always, if you are have thoughts or colleagues that you think would be great members or other organizations who are not members, please send those names over to the executive subcommittee and we can extend invitations and then the committee would vote. And Emily Griffey from Voices has left Voices. She went to University of Richmond, I think in the development department. And Emily Moore, who is at Voices now, has been is being put forth by the executive subcommittee for membership, for consideration for membership of the committee. And her questionnaire is after the minutes from the June meeting, correct? Sorry, let me double check the order. Yeah, so her questionnaire is after the page with the proposed meeting dates on it. So you can take a moment and review that. And then if anyone would like to motion and second to have her join the committee.
Do we need a nomination?
We need a motion and a second.
Move to nominate Emily Moore.
Thank you.
Second.
All right, and all those in favor of having Emily join the committee, please say aye.
Aye.
Any opposed? No, great. And then the last membership update is myself. So I will be leaving BPLC at the end of next week. And so I will no longer be the committee chair for CHIPAC. This happened after the last executive subcommittee meeting. And so at the next one on October 13th, the executive subcommittee will be considering nominees for the committee as well as nominees for chair. And if it becomes Freddie, who's the current vice chair, then the vice chair position as well. So if anyone wants to have either of those positions, or if you want to nominate anyone, please let Hope know, or Emily Roller, you might be like, and Freddie, our last executive subcommittee meeting members, Heidi, as well. Let them know, and that can be discussed at the executive subcommittee meeting. Also, as always, those are open meetings too, so anyone's welcome to join or join online. But I'm not going far. I'll be joining DMAS, so I'm sure you'll still see me around. And with that, we're going to turn over to Trisha Brooks, who's online. Trisha, can you hear us? Are you good?
Yes, I can, Sarah. And I'm sad to see you leave your current role, but I'm glad you're going inside to get good things done. So congratulations.
Thank you. So for those of you who don't know Trisha, she is a research professor at Georgetown University McCourt School of Public Policy Center for Children and Families. You've often likely seen her name on many documents and briefs and reports that come out of the Center for Children and Families. she has a distinct focus on eligibility, enrollment, program administration, and the quality of healthcare related to Medicaid and CHIP coverage, particularly for children and families. She's also a former CHIP director from New Hampshire, I believe. Correct me if I'm wrong there. And has just spent a career working in the Medicaid and CHIP space is a wealth of knowledge, and is the lead co-author of the 50 state survey on Medicaid and CHIP eligibility, enrollment, and cost sharing policies. And so we invited Tricia here today to just kind of give our committee a good baseline of where Virginia stands in comparison to other states, what options we've adopted, what options could potentially be available to us as a committee to recommend to DMAS as well as the administration to strengthen these programs and strengthen the support for children and pregnant individuals in Virginia through these programs. And kind of in line with the thoughts of kind of taking a step back before writing letters as a committee or making recommendations, just getting a really good kind of baseline understanding of where we are so that we can make those recommendations in a really well-informed manner. So Tricia, we're so happy to have you here today. And with that, I will turn it over to you. Thank you.
Thank you, Sarah. I really appreciate it. And good afternoon, everyone. It's a pleasure to join you today because there are few things I enjoy more than talking about how states can improve health coverage for children and families. So in case you're not familiar with the Georgetown Center for Children and Families, or CCF as we call ourselves, we are a nonpartisan research and policy center located in the McCourt School of Public Policy at Georgetown University. We were founded in 2005 with a mission to support access to high quality, comprehensive, affordable health coverage for all of America's children and families. One thing to note is that the center is completely philanthropically funded. We do not accept money from government or industry. So with that, we can jump in. I think we can go down 2 slides. And I just want to do a double check on audio. I'm getting some feedback in my AirPod. Are you guys getting feedback there?
No.
Okay, as long as you can hear me, I can deal with this. So, okay, we're going to start by looking at data that the Kaiser Family Foundation and Georgetown CCF collect in the annual 50-state survey on Medicaid and CHIP eligibility, enrollment, and cost-sharing policies. Next slide, please. So let's start with eligibility. Unfortunately, Virginia is on the low end of the income eligibility scale compared with the nation and with surrounding states. Virginia's upper income eligibility at 205% of the federal poverty level is the same as Arizona, Nevada, Utah, and Wyoming, and not much higher than the only 2 states with income below 200%, and that's Idaho and Nevada. And yet the cost of living in parts of Virginia is higher than those mountain states. The median income nationally is 255% of poverty, with more than 1/3 of the states covering children at or above 300%. Next slide, please. Now, the state fares a bit better on pregnancy, which, as you all know, is very important for child health and development. Here, Virginia is one of only 7 states that use CHIP funds to cover pregnant adults. Virginia's upper eligibility level at 205% is just below the national median of 207%. And you more or less fall into the middle of the pack compared to neighboring states. Next slide, please. So Virginia has also maximized the use of federal funding to cover immigrant children and maternal populations. The state has waived the 5-year period, that is the waiting period, for both children and pregnancy coverage. The state also adopted the unborn child option, allowing the state to cover pregnancy regardless of immigration status, with the intent of ensuring the health of the child prenatally and at delivery. However, a dozen states also use state-only funding to cover children regardless of immigration status, while 11 states cover targeted groups of immigrant adults. And those numbers are very small, by the way. I was trying, at least of immigrant children, I was trying to take a look at those earlier and never got around to it, but I'm going to follow up with Hope and Sarah with that estimate. Next slide, please. Now, I actually found the analysis in the next two slides to be very interesting in terms of the trends in Virginia's child Medicaid participation and your uninsured rate. Virginia's participation rates, I think we can go to the next slide. There we go. So the arrow is pointing to Virginia, and this shows your neighboring states and the highest and lowest and the average in the US. So your participation steadily increased from 89% in 2013 to 90.7% in 2016 to 93% in 2019. But now, if you look at your neighboring states, you'll say that in most states, participation levels dropped between 2016 and 2019. Now, you might be wondering why, or you may already have some thoughts. The Trump administration's approach to Medicaid and its immigration policy had a chilling effect on enrollment. However, I would attribute your continued growth in enrollment for children to Medicaid expansion. It's well documented that the welcome mat effect of increasing coverage for adults has a positive impact on children's enrollment, even though their eligibility levels did not change in the Affordable Care Act. Next slide, please. Now, we all know that Medicaid and CHIPAC are a primary source of coverage for children. As such, there's an inverse correlation between participation rates and coverage rates. When participation increases, the uninsured rate goes down and vice versa. So as you can see here, Virginia's uninsured rate also steadily declined between 2017 and 2021. Now, we're not surprised about 2021. And I realized after I sent the slides to Hope that it might have been helpful to use the same years for this analysis. But if you look at 2017 and 2019, you'll see that the uninsured rate for children increased. The coverage rate for children increased when participation rates increased from 2016 to 2019. And they, of course, bumped up again in 2021 as a result of the COVID-related Medicaid continuous enrollment requirement. So here in both of these slides, Virginia was bucking the trend, and I commend you for that. Next slide, please. So next, I'd like to turn to policy systems and services. On the next slide, we're going to start by talking about continuous eligibility. If there's one thing the Medicaid continuous enrollment requirement demonstrated, is that stable coverage reduces churn and lowers uninsured rates. Household income fluctuates more for low-wage earners than higher income earners. As a result, low-income kids can churn on and off coverage, resulting in delayed care with increased use of emergency room services. When uninsured, families avoid preventive and routine care that can impact health and development of kids, particularly young kids and adolescents. So as part of the Consolidated Appropriations Act, Congress took a step in the right direction, requiring states to provide 12-month continuous enrollment for children. Currently, Virginia is one of the 24 states that has not voluntarily adopted the option. But still, 12-month continuous eligibility won't prevent churn at renewal. So other states are not stopping there. Oregon and Washington State have received Section 1115 approval to cover young children continuously until age 6. Several other states are moving in that direction, including California and New Mexico. The fact is that most children, particularly young children, live in families whose income doesn't render them ineligible, but they get caught up in red tape and administrative barriers to coverage. So here's my soapbox. The entire 30 years I've been working on children's coverage, we keep talking about bending the healthcare cost curve. These efforts tend to focus on controlling costs for people with significant health issues. But we keep filling up the pipeline of adults with multiple chronic conditions that are rooted in childhood. If we really want to bend the cost curve, we need to start with children and boost spending on social services to ensure that children have all that they need to grow up healthy and become productive adults. Children who are covered by Medicaid are healthier than uninsured children. They miss fewer school days. They do better in school. They're more likely to be better educated and earn higher wages as adults. So obviously this is a bit of a hot button for me. So let's next turn to maternal health, which, as you know, impacts child health and development. Virginia is one of the 46 states that have picked up the option to provide coverage for 12 months postpartum. But you could do more. Keeping parents covered is also important to child health. Not only are they better parents, but when they are in good health, as I noticed previously about the welcome mat effect of Medicaid, kids are more likely to stay covered if their parents are covered. New York provides 12-month continuous coverage for adults, and Illinois is seeking approval to cover all Medicaid enrollees continuously for 2 years. Next slide, please. As mentioned earlier, research shows that the time more children lose coverage is at annual renewal. The Affordable Care Act implemented policies requiring states to improve their systems and the use of data to make data-driven eligibility determinations at renewal, as well as for new applications. If you've wondered why these automated renewal processes are known as ex parte, it's because they rely on reliable external party data to determine ongoing eligibility. Higher ex parte rates lower procedural disenrollments, promote continuity of access to care to better manage those health conditions, and they create administrative efficiencies, which free eligibility workers to focus on more complicated cases, such as families with self-employment. Although states can improve their ex parte rates, Virginia should be proud of its record on ex parte. On the 2023 survey, the state reported ex parte rates in the 50 to 75% bucket, along with 12 other states. But the unwinding of the Medicaid continuous enrollment requirement has revealed that very few states actually achieve that level of automated renewals. With 2 months of unwinding data, Virginia is tied with Maryland for the second highest ex parte rate at 53%, behind only Arizona at 65%. Continuing to improve your ex parte rates will have many benefits: removing red tape, reducing churn, and increasing administrative efficiency. And these are 3 concepts that I will probably hit on multiple times in this presentation because there are so many improvements that do all of those things. Next slide, please. Now, I didn't actually put this in the slides, but I wanted to note that Virginia is one of some 27 states that have SNAP and TANF integrated with your Medicaid system. And the state is only one of 14 states with integrated child care assistance. Don't change this. Integrated systems provide access to some of the services like food and childcare that families need. And it's my understanding that the plan is not to move Medicaid into your state-based marketplace system, which is coming live soon. And that may be a good thing because states have learned that it gets very tricky. There are only 10 of the 21 SBM states with integrated MAGI Medicaid and marketplace systems, and only 2, Rhode Island and Kentucky, include non-MAGI Medicaid and other benefits. So state-owned systems, Virginia's online Medicaid accounts offer broad functions. Of the features we query on the 50-state survey, Virginia is only missing access for authorized representatives. Now, individuals can share their online logins with authorized reps, but there's no way to distinguish who entered that data or made the change. So I would encourage Virginia to explore adding this feature. Additionally, the state has not confirmed that it has ensured mobile friendliness of its online accounts for smart devices, although they may work. Evaluating mobile friendliness is a step in the next direction, but a handful of states have launched actual apps specifically designed for smartphones and tablets, and I would encourage you to think about that. Another opportunity is for Virginia to launch an online portal for assisters and community partners to facilitate application and renewal processes. Assister portals, which 29 states have, again, create efficiencies, they reduce manual data entries, and they promote enrollment and retention. If you're interested in exploring a robust integrated system, as well as full function Assister portal, I would suggest you look at Kentucky because they are, of all the systems we've looked at, the highest functioning. And as I mentioned before, they're one of the only 2 states that have that fully integrated Medicaid and marketplace system that also includes the non-health programs. Now, I'm not going to pretend that managing that many programs within the system is easy. It's not, but it certainly benefits families by giving them access to multiple benefits. Next slide, please. So here's an area where Virginia gets an A+, and that's in regard to cost sharing. You know, many years ago, and I'm talking about well over a decade, the state dropped its $10 CHIP premiums after determining that it actually didn't generate any revenue, and it was a barrier to enrollment. And it is currently, Virginia is, one of 24 states without premiums or enrollment fees in either Medicaid or CHIP. A number of states actually suspended those premiums or cost sharing during the pandemic, but Virginia took it a step further and permanently discontinued cost sharing for children effective July 2022. So kudos to you. However, the state has not adopted presumptive eligibility, which allows qualified entities like healthcare providers, schools, and other organizations to be trained and screened for eligibility and temporarily enroll children and others while the full application is being processed. PE, as we call it, is an effective policy in accelerating access to care and encouraging families to complete the application process. Now, by the way, I'm talking about traditional presumptive eligibility, not hospital presumptive eligibility, which was mandated by the Affordable Care Act. And as you can see here, more states use PE for pregnancy than children or adults. One consideration in adopting PE is to examine the average time it takes for a new application to be processed. Delays in approval result in delays in care that may increase the cost of care after enrollment. Next slide, please. Now, I know this committee has looked at the benefit of providing full EPSDT services to children. Currently, FAMOUS offers benefits that are comparable to the state employee plan, plus some additions. But EPSDT is particularly important for children with special health care needs. Currently, 2/3 of the states provide full EPSDT in Medicaid and CHIP, including the 19 states that cover all their children in Medicaid. Offering EPSDT streamlines your parent education, the administration of the program by the plans and by the state, as well as service delivery for the plans and healthcare providers. But when you take a closer look at your enrollment, you actually see that 90% of your children are receiving EPSDT services in Virginia as Medicaid or as your Medicaid crossover group. So let's dive into this a little deeper on the next slide. The state should consider merging FAMOUS into your Medicaid crossover group, and it's my understanding you guys have talked about this. The advantages are significant, including easing administration, allowing access to drug rebates and the Vaccines for Children program. It also avoids those funding cliffs, like what happened in 2017 when CHIP funding temporarily lapsed. I think Virginia was one of the states that alerted families to the potential for a loss of coverage at that time. And that creates a lot of stress for families and providers. There are a growing number of states that are covering children in Medicaid, including recent adoption in Illinois, Maine, and your neighbor, North Carolina. Now that is coming from a former CHIP director. So one thing I will tell you that I think CHIP did for children's coverage was that it made marketing and outreach a good thing. It was okay to brand your CHIP programs. It was okay to use colorful marketing materials. And all of that really was a welcome mat effect of enrollment in Medicaid. One thing I would not want to see the state do if you were to merge your kids into the Medicaid crossover group is to keep maintaining your outreach and focus on children. And I certainly hope that this committee would continue to be the watchdog for that. Next slide, please. I am not going to go through all of the data on these slides or the information on these slides because this is not my area of expertise, but I quickly want to recognize the youth mental health crisis in America. And it's not isolated to adolescents. I mean, some people shake their heads when we talk about mental illness or mental health concerns in young children, but they do exist. Addressing this crisis really requires a comprehensive approach. I'm sure, as you all know better than I do, and that Medicaid and in the schools is an important part of the solution. To this end, CMS has been working to make it easier for states to cover Medicaid services in schools. And I know you're doing a lot on this front, but I didn't want to skip the topic. Next slide, please. So now we're going to pivot to program improvement. We can go on. Next year, states will be required to report all child core set measures of healthcare quality in Medicaid and CHIP. The final guidance was just released, and I have all 100 and something pages sitting behind me here, and I haven't read them yet, although I did take a close look at the proposed rule, and I also serve on the annual core set review committee and have for the past 4 or 5 years. So this is near and dear to my heart. But as we move forward, states are going to be required not only to report these measures, but also to disaggregate these data. I would encourage you to make sure that you're not only tracking, but trending the state's outcomes and stay on top of the state's quality strategy and its improvement priorities. So this is sort of the cycle of, looking at the measures, determining where there are opportunities for improvement, making sure that those opportunities get into the state's quality strategy, and then also get into your managed care contracting. If you look at the state's managed care external quality review reports, which are not an easy read, I can tell you that, if you can find them, they will provide insight into performance improvement projects. So if you look at those, all you have to do is search for the words child, pediatric, or maternal to discover the extent to which performance improvement is focused on children. I'm happy to answer more questions about measuring and improving the quality of care, but for the sake of time, I just want to note, I often hear stakeholders say, I am not a quality expert. This is all Greek to me, but you don't have to be an expert to be a catalyst for change. Next slide, please. Consumers and partners are an important source of insight. When I ran New Hampshire's CHIP program, we conducted biannual surveys of new enrollees, established enrollees, and recent disenrollees. And the results helped to supplement and give context to quantitative data that we had. So for example, who were kids who were losing CHIP moving to other health insurance? We could ask that question of disenrollees. If someone was disenrolled and they stopped paying their premium or whatever, we could ask them, was the premium too high or did you get other insurance? Those sorts of intel help to again, enrich the quantitative data that you have. And though it was not a big part of my world as CHIP director in the 90s and early 2000s, social listening and using social media to communicate with enrollees and eligible families are effective methods to hear and get insight from how families feel about the programs and also your application and renewal methods. Now, this committee is a good example of a feedback loop, which gathers intel and impact while hearing from the state on opportunities and challenges. It's also important to stay in touch with other stakeholders, particularly navigators and assisters, as well as community health centers who have direct relationships with families. Now, as we can see in the next slide, broad feedback loops engage all partners in what is essentially quality improvement, continual quality improvement. These feedback loops enlist a cadre of partners who are willing to help maximize coverage and troubleshoot problems. They're particularly helpful when policy or system changes are implemented, like now in the unwinding, and they support two-way communication and build trust with partners. So moving on, I want to spend a little time on the unwinding. We can go down 2 more slides. This is an extremely vulnerable time for children and family coverage. As I noted earlier, renewal is the time children are more likely to lose coverage. And parents may not realize that their children are likely to remain eligible even if they are not. Now, ASPE projected that 3 out of every 4 children who are disenrolled will remain eligible. And the risk is also higher for people of color compared to whites. One thing to consider is whether some of the temporary unwinding strategies, Virginia's picked up, I think, 10 of the waivers offered by CMS. Do we want to make those permanent? Has that assisted in keeping people enrolled in a way that we can make a case that these options should be permanent options for states? So it's incumbent on all of us to look at those options and advocate for change as warranted, because some of these are not available at the federal level currently that are not associated with the unwinding. Next slide, please. So this slide really makes my heart feel good, because I want to commend your state on your more positive outcomes for the unwinding so far. As you can see here, Virginia's 53% ex parte rate compared to the national median of 24% is outstanding. As a result, your share of disenrollment at 37%, which we'd rather not see, is much better than what the median is at almost 55%. Next slide, please. But shouldn't FAMOUS be growing? The Urban Institute estimated that 57% of children losing Medicaid would be eligible for CHIP. But as you can see here, Medicaid has decreased by almost $24,000. I mean, not dollars, sorry, 24,000 children. That's really good compared to other states. But FAMOUS enrollment has also declined, not by much, by a little bit. And yet there's a $14,000 differential in the upper income for Medicaid compared to FAMOUS. So I guess I just don't understand why we aren't seeing FAMOUS enrollment grow. And I would want more information from the state on potentially the income or the reasons these children are losing coverage. Because if they aren't transitioning to CHIP, are they over income? Or are they losing for procedural reasons? Which means that we're going to have to double down and boost our outreach and reconnect families with coverage. Next slide, please. And you know, Virginia knows how to do this. This is something that astounds me. We have not actually put a brief out on this, but we've done the analysis, and at some point we'll get around to it. Outreach is required in CHIP. And it's not just outreach for children eligible for CHIP, it's outreach for children eligible for any coverage. And I guess I just don't understand why states are not reporting CHIP outreach expenditures, because Virginia is only one of about 10 states that are consistently reporting these expenditures. Now, other states may be embedding that in their administrative cost, but how do we know whether states are investing in outreach if they don't break that out? Virginia's investment almost doubled between 2018 and 2021, but your outreach expenses are about 2.5% of total program administration. And program administration is averaging 5 to 6%, which is well under the 10% CHIP administrative cap. So there actually is wiggle room to do more. Next slide, please. And one thing I want to really emphasize about how Virginia is promoting your programs. And unfortunately, I think there's a lot of room for improvement here. Now, if you were to merge your kids from Famous into the Medicaid crossover, this might not be the problem that I see today. But what you are doing is promoting programs. You are not promoting coverage. You list separate income levels for different eligibility groups, and that's really confusing for families. You can help families understand they're eligible with messages like children in a family of 4 earning up to X amount may qualify for coverage. You also need to ensure that transitions from Medicaid to CHIP are seamless for families, which is another reason to dig into a little bit about why your Famous enrollment is not growing during the unwinding. Next slide. So I'm going to sum up, and I'm really happy to engage in Q&A. I don't know if I've run over time here, but I just want to sum up some of the things that I see as opportunities to improve coverage. So consider multi-year continuous eligibility for young children. Consider covering all children. Raise your income eligibility for children. The median is 255% of the poverty level. There's a lot of difference there with Virginia's rates. And as I mentioned earlier, you have some really high cost areas, high cost of living areas. Also, brand and market your programs as a continuum of coverage options. Develop and launch that assister portal. Offer EPSDT services for all children, or better still, merge Famous into the Medicaid crossover group. Improve your quality through ongoing consumer research and engagement, and in the review of quality metrics and improvement plans. And pay attention to unwinding outcomes. Boosting outreach and assistance will likely be needed to reconnect kids to coverage as we move forward. And with that, happy to take Q&A. Thank you.
Great. Thank you so much, Tricia. We're just open up for if anyone has any follow-up questions or comments.
Trisha, this is Shelby.
Hello, Shelby.
Hi. Trisha, I'm curious to hear if you all have begun looking at states' methods in translations, and especially around the unwinding in particular. I've been increasingly concerned. I mean, I think Virginia, we have done quite a bit of translation of our notices and our outreach materials and such. But I am curious, where do we stand with looking at, other states as well, if that's an area that CCF has begun exploring at all?
Shelby, no, I have to say we have not. Our hands are so full trying to just even track down the data, because the 3 to 4 month lag in CMS reporting data is not acceptable, in my opinion. It does not give us timely enough data to figure out where the problems are and where mid-course corrections need to occur. So I think that the National Health Law Program probably has taken more of a deeper dive on this. but I will tell you that in our feedback loops with child health advocates and other stakeholders around the country, we are hearing that access to interpretation in call centers, being able to get notices in your preferred language are just significant problems, huge problems. We heard about Texas sending out notices where one paragraph is in Spanish, next paragraph is in English, not a repeat of the prior paragraph, a different set of information. And it's just amazing to me that we are here at this place. And I know that Unitas USA has really brought together groups to talk about the civil requirements for language access. And so I have a feeling, Shelby, you know a lot more on this subject than I do. So I'm sorry I can't lend more information on that.
Oh, while we're on the unwinding, can I ask the state folks here about, we saw that the CMS guidance that talked about ex parte and the individual versus household. And when I saw Trisha's data and how we are, doing in terms of ex parte compared to other states, my hope, that is not applicable to Virginia. It sounds like you all might be doing it at an individual basis, or can you tell us more about what your thoughts are?
We're still digging in. So we've engaged DSS, we've engaged Showlake. We're digging in and going through everything. We want to make sure we have all of the information right. It's unfortunate that we didn't get the guidance until last week. I will say, as a state, we're a little bit disappointed that we didn't see it sooner. We do have some outstanding questions with CMS. So there's some questions around Parliament's continuous coverage, what that's going to look like with some of the new guidance. We were talking today about CHIP. There's some unusual rules that they're telling us with CHIP that we're not quite sure if that's happening correctly in ex parte. So there's still a lot of questions, I think, even with the guidance that they have provided, that we're digging through, and we should have better answers next week. We actually have a call with them today where we're going through, but and we're actually meeting with CMS next week. So we'll be letting everyone know. But I mean, I think, Shelby, if anything that we find that is not up to par, we're definitely going to get it fixed. But, and we worked really hard on our ex parte, and we're going to continue to do that and make improvements there.
And if I can jump in here, for those of you who may not have read the news headlines, it was breaking news with CMS last week. What is happening is that some states are not going ahead and renewing eligible children, and sometimes other people, if there's at least one person in the family who isn't eligible. So it's not the way things should be done. And it was interesting hearing the comment about are you building that ex parte to move kids into CHIP? That's an interesting tidbit for me to ponder a little bit. But I don't think you've got as big a problem as other states, if you have any at all.
I agree, Tricia. I think we're in a good place in Virginia, but we want to make any tweaks that we can. The CHIP issue, if you come up with anything as you're thinking about that, let us know. Because we are struggling with what we're hearing around not renewing or placing a child in CHIP during the ex parte process. But then if the parent or caregiver did not return their packet, to then later go back and evaluate the child for CHIP, it's a little bit confusing, and it seems to me like we would really have some children falling through the cracks in that area the case, and, you know, we were kind of pondering that this morning. Why would you not go ahead and put the child in SHIP during the ex parte process, and then if the parent returns the packet and it's different, you can always move the child back.
Sure.
Because our benefit plans are different, so it's an adverse action in Virginia to do that, but so anyway, it's a little bit concerning, and, you know, everyone's scrambling to make sure systems are in place as quickly as possible, like 12 months continuous coverage. We don't have a lot of time to get that in place, and we still have outstanding questions around that piece.
Yeah, CMS has not released guidance on 12-month continuous.
Exactly.
But we had it in January 1st, so that's tough, you know.
Yeah.
To get these systems changed.
They told me it was going to be late in the year before that guidance comes out. But if you're not building CHIP enrollment, if you're during the ex parte process, it would explain why Famous is not growing.
Kind of changing the subject now, but going back to one of your slides earlier, Tricia, and sorry that I'm mic hogging. I'm sorry, I'm taking up so much time. But you brought up something that I was pondering a little bit. We were talking about how we're one of 20 states that provide coverage to people during pregnancy, regardless of immigration status, and also through Famous, and also even higher income, which is wonderful. That group isn't required to have 12-month postpartum, but do we provide 12-month postpartum to them? And I do believe that there are some states, maybe Vermont might be one of them, that does do that with a waiver or with state-only dollars. So in my world, I would want all people who to continue, you know, have 12-month postpartum coverage. So I would add that to Trisha's already wonderful list of items to keep in mind. So Trisha, I don't know if you know of any of the states that provide that 12-month is it Vermont and maybe one other?
Yeah, maybe. So I think there's movement in this direction. Some states have been using CHIP, Health Services Initiative funding, to cover certain services in postpartum, because technically, I noticed that Shelby avoided calling it the unborn child option. It's the way people know it, but it's the child that's covered. So when the child is born, the child continues with coverage, right? But the mom does not. And it's an important point to make, Shelby. And I think you'll see more states moving in that direction. I just think there's a lot on everyone's plates, but I can dig a little further. I know that NASHP has a dashboard that they've been tracking the use of HSI funds for either prenatal coverage or postpartum coverage. And that, I don't know if they've updated that for the 12 months at all.
I can add a little bit of clarification. We do have an HSI, and that's what gets us to 60 days.
Right.
So the mechanism would be we would extend that HSI, and states can do it for up to a year. And there are a number of states that have done that, especially trying to align it with if they have the 12-month extended postpartum coverage. The kind of history of why it ended up the way it did in Virginia is because of the timing of when those two changes got made. So I think Famous Prenatal was in the budget, and then 12 months postpartum happened, and they ended up moving along independently of each other. And so we ended up with a mismatch in the postpartum time periods, but that's certainly something that the state could look at changing.
Hey, Trisha, it's Emily Roller from the Virginia Healthcare Foundation.
Hello, Emily.
You have piqued my interest, to say the least, with regard to an assister portal in our web functionality. And so I'm grateful for your suggestion of Kentucky as a good model. I was curious, too, about the mobile friendliness. Are there any states that you've found are doing a mobile-friendly application and or case management portal exceptionally well?
I think that Kentucky is your model. And the reason for that is it's not, it, it, the Kentucky model allows an assister, let me use the term account manager, to be, so you're my counselor or whatever. You're the person who keeps me or my family connected to coverage. And so Kentucky allows states to, or allows assisters to get alerts when renewals are due and things like that. So if you look at the Kaiser 50 state survey, we ask about the features of these portals, and we ask about it similar to what we ask about online accounts. And I think you'll gain more insight if you look at that particular table that I'm looking for in my report right now. But I can tell you a table number in a moment, but that'll be a good source of information for you. It's table number, nope, not 12. I thought it was 12. Goodness. All right, never mind. Oh yeah, it's table 11. And so you'll see a bunch of features, whether you can submit an ad, review application status, report changes, view notices, view actions required by the enrollee, submit renewal information, upload documents, update mailing addresses. Those are the features we queried.
That's great. Thank you.
Fantastic. I think that brings us to time. So thank you, Trisha, for such a great, detailed, and perfectly timed presentation today. I think we will share your slides with the committee after, right, Hope? And so if anyone has additional feedback, either for CHIPAC or for Trisha, there will be, plenty of opportunities for directly contacting us as well. And yeah, thank you again so much for joining us.
You're very welcome. And please, we are here to be a resource for anyone who is looking to improve children's coverage. So don't hesitate to call on us if we can be of help. And have a good rest of your meeting.
And that brings us to our next agenda item, which is unwinding updates. Is that Jessica still or Sarah? Oh, the questions kind of brought us to that time.
Okay.
Sorry.
Yeah, I will take it. All right, so I know you guys probably have more questions than I have content to go over, so that's good. So we'll fill the time with your questions. We can go ahead and go into the first slide. First, this is our same data that was on the previous slide. Oh, okay, we go to the next one. This is just our recap slide. This is, how we got to where we were in the unwinding. Nothing's really changed here. This is, of course, what's happened over the past couple of years. So now we can go ahead and get into the data on, okay, so how is unwinding going? So the next slide is our dashboard, just a snapshot of it. Just want to give a huge shout out to our healthcare analytics division. They just changed their name a couple of months ago. So of course, we're trying to make sure we say the right acronym. They did a major refresh to our dashboard. The first couple months of unwinding, our dashboard was very limited. It kind of just bucketed people, and even the buckets were not very aptly named. Didn't really give any information other than just kind of this is where people are. So this is actually just one of, I believe, 4 different tabs that we have now for our dashboard. This is just the overview. But if you've looked at our dashboard, you know that there's a lot more information just on this first tab than what you've seen before. So this data is actually as of August 30th. I do have more updated numbers in front of me as the dashboard is now being updated on a weekly basis. Another great change because it was monthly before. So the data you see in front of you is as of August 30th. If you had noticed over August, of course, the closure numbers declined. You'll see that every month because, of course, people turn in the renewal forms, they're reinstated during the reconsideration period, that 3 months after you're procedurally closed. As well as if you appeal, we still have the flexibility that was talked about in the previous presentation where appeals still automatically grant you reinstated coverage with no repercussions, nothing as a result of the appeal that we would ever go back for any of those claims. So what you'll see now is because this is updated on a weekly basis, the closure numbers will be the highest at the beginning of the month. For example, this is as of right before the last day of the month. Almost all of our closures are at the end of the month, except for reasons like death. So we were at 130,000. Now the new data refresh is 184,000. So of course that increases the number of people that closed at the end of the month. So basically that's just the difference between 830 and if we had pulled this on 9/1. That being said, we also increased slightly the number that were renewed and continued. So that was one of the things that was a little confusing before. So we considered if someone is completed, that means one of two things happen. Either their coverage was closed or they were renewed and their coverage continues. So completed is basically a sum of both of those. Coverage being closed doesn't necessarily mean it was closed because of the renewal, though. Of course, there's things they can report, such as moving from the state or the member is deceased, and we would take action on that prior to the renewal. We also added a lot of the demographic information that you see below, a little bit different than some of our other demographics. For example, member age, we kind of wanted to do that to align a little bit more with, our different eligibility groups. So we kind of have the children as 0 to 18, then we have our adult groups that are 19 to 64, and then 65 plus. So as you can see here, age, race, ethnicity, and gender is there. Now it's interesting to me because the unwinding progress, that little donut that's kind of in the middle on the right hand side, it was 37% last week, 39.9% completed. That means we've only had 4 months of renewals due, even though August was month 6 of unwinding. Of course, we start our process 2 months early, so there's been 4 months of renewals that we needed to complete. Think about that over a 12-month period, we should be around 25%. We're at 39%, which means that we've completed redeterminations for almost 40% of the entire population we knew that we would need to redetermine at the beginning of unwinding. So that's huge news. That's great news. There's still a ton of work to do. We're not going to deny that there's always going to be backlogs there. You guys see the CMS reporting. You know that not all the work is completed, but we just want to make sure that we're always pointing out the tremendous amount of work that the local agencies and Cover Virginia have been doing to complete these redeterminations, while at the same time come into compliance with applications, and not to mention, of course, the local agencies having to process the other programs as well. So the new total as of yesterday's refresh was 864,323 members have completed their redetermination. We can go ahead to the next slide. Of course, we know we want to focus on closures because we want to focus on the who and what's happening, with the individuals that are closed. The ratios are just about the same. Of course, the numbers have increased a little bit because closures have increased. Non-ABD adults, those low-income families with children, and expansion covered groups, those are our highest closures, followed by children. There's a lot of information and public information about children's closures, which is kind of already talked about a little bit with making sure that we're not procedurally closing anyone inaccurately. We'll go ahead to the next slide because this breaks it down a little bit better. I have an extra slide in there. I forgot about this one. So overall, this takes all the closures and what are the top reasons. So this is regardless of coverage group. One thing here that makes it a little weird is it still makes it look like failure to complete renewal looks really high compared to the rest of the reasons, but we are still closing more individuals for non-procedural, meaning we determined them ineligible, than those that did not return their information. And that's really important because determining ineligibility is also what transfers their account to the marketplace for other coverage. Of course, there's some individuals that don't get transferred, but that's one really important note is that through our outreach and just any time that we're able to speak to anybody to say, even if you think you're not eligible for Medicaid or CHIP, turn in your information because we can also help get you to the marketplace to look at some other affordable options there. Let's go ahead to the next slide. Yes, so this breaks this down as well under kind of the main groupings that we have on our dashboard, our main populations, and then compares the procedural to non-procedural closures. So you can see that, like I said, the procedural closures are less than non-procedural closures in most of our groups. The closest one being that limited coverage. The majority of that is, of course, our family planning, our Plan First, Medicare savings plans, incarcerated coverage, and emergency services. All of those kind of limited coverage groups. So you can also see kind of the breakdown of procedural versus non-procedural there. And I think this was my last slide. If we could go to the next one, just to make sure. Oh, the ex parte numbers. So yes, we all forget about ex parte. Oh, even though I do update these presentations, I swear twice a day. So ex parte numbers, we're tracking that, as you can see, our baseline, which was before March of 2020, we were about a 50-50 rate for cases and members. And so you can see kind of how we went through the unwinding. Started off really strong because we also had a majority of what we started with were current due, meaning those that weren't overdue, that had their eligibility looked at in the last 12 months. Once we started looking at our overdues, or those that had a renewal due more than 12 months ago, those numbers did start going down. But you can also see the last 2 months, we had some significant improvements. So, you know, we always look at our processes, and I would say that some of the things that helped us here is actually seeing some things that we could do to increase ex parte, making sure we're putting the right people through, and then making sure that we're taking away any barriers that might have dropped somebody in a process sooner than they should have. We had a lot of preconditions that we ended up working through and saying, you know what, some of these people we can go ahead and still attempt. So kind of talking about some of the things we're looking at. So we saw our greatest increase, you know, in ex parte since the first month last month. So pretty good to see that we're back up to 51% of our members, which is great because that's not only currently due, but overdue members as well. We do expect these rates to stay relatively the same through the next couple of months of the unwinding, as we continue to put in, you know, any of those other improvements. All right, let me not lie and just go to the next slide and see what happens. It's the last one. See, there's another one. Just some other metrics for you guys to see, you know, on our appeals. As you can see, the baseline and they, you know, where they are in terms of their numbers, how much the appeals have grown. Majority of the member appeals are due to the renewals at this point, but really want to applaud appeals work. The total number of client appeals that are overdue is still 0. And that's amazing. I mean, they were able to ramp up by hiring some ARPA funded staff to be able to supplement their work, but just amazing that they've been able to keep up with that. And again, with the appeals, we do have the flexibility that coverage is reinstated. So that's part of the appeal. It's normally the member would have to actually attest to wanting that outside of this flexibility. So again, another thing where we always say, you know, sometimes I know the appeal process can be a little bit grueling, but we always want to make sure that the members are afforded that appeal right. Request for information is something that we always look at, and we've also been looking at, you know, the total numbers versus what's unwinding related. July says 0, nothing for unwinding. But you know, we know that's not going to stay the same. We'll continue to get the questions and answer them as they come in. But again, I think that that's, you know, showing our progress during the PHE to actually get our websites updated, get all the information out there so that way it's publicly available. I think with the dashboard refresh, that also has greatly helped a lot of the questions that we were getting, that we had access to data but wasn't out there. So the transparency to data, I think, is pretty clear with the dashboard updates that we've made. So just continue to plug that if you're not looking at it, definitely go look at it, and you can look at it more often now because we're updating it weekly. Next slide. All right, so that is my closing slide. So I think that there might be some, you know, additional slides in the appendix, just some information where if you might have not seen this before, some additional slides that we've given information on. And at this point, I will pause for questions.
Do the folks here know about the recent, I know you haven't kind of figured out what you're going to do, but the recent missive from CMS about ex parte?
the individual versus household issue, yeah, that's what, we were kind of touching on a little bit earlier, that we'll have some more answers next week.
Just wanted to make sure people are aware.
I think, unless anyone has any questions about it, that's what, Tricia and I covered a little bit with the individual versus household issue.
Another kind of question that Tricia kind of brought up, but we haven't quite explored that much is I am curious about what's happening in terms of overall enrollment in Famous Plus and Famous, and how do you all have suspicions, or like what were your thoughts about what Tricia was pointing out in the data, and what are your suspicions about what might be happening there? And yeah.
So I would say that you know, overall we kind of look at children's enrollment, which is interesting because we look at it as a whole, not
Right.
necessarily, you know, Medicaid versus CHIP, but we do have, I actually have a slide here that I'm looking at right now, which breaks down those top non-procedural closure reasons, which is also on the closure dashboard. So when we say the children, when we're looking at the number, this is just what they're enrolled in at the time they're redetermined. So that's one really important thing to point out. There's a lot of kids that have turned 19, you know, since 2020. So that's part of it too. And I believe that this is one theory, but until you can talk to a member, you don't know. Are some households not turning in their renewal form because the child's no longer there? And instead of telling us where the child is so we can, you know, take their case and you know, move them into their own household without knowing that. And that's been one of the big struggles with states is if you don't hear from the household, you don't know why. You know, is it that the parent thinks, oh, well, I'm no longer eligible, so my kids aren't, which of course we say, you know, still turn it in, and you might not know about all the programs that are available to you. But we definitely have a large number that don't meet those non-financial requirements. So that we'd have to work with DSS a little bit more to look at the cases. So is it that maybe were they over income for Medicaid, but have TPL? So then we'll be able to find that eligibility in Famous. That with 12 months continuous, you know, we'll be able to protect them a little bit longer. I know we're talking about renewals, but that could be part of it. We do have out of the most recent numbers, approximately it's a little bit less than 10% are over income. That means they were over income for both Medicaid and CHIP. Now, some of them, of course, will go on a spend down and may meet that spend down and become medically needy, but they were just completely over income. I know it's income/resource because we have one closure code that captures them, but we know with children, no resource test unless you go to medically needy. And then actually the third highest loss is actually loss of Virginia residents. So people that moved. We did a lot of cleanup work, of course, to make sure that, you know, we were maintaining coverage for those in the state and to make sure that we didn't have too much renewal work. If someone did move, of course, appropriately closing coverage if they've moved permanently from the state. So some of the closure reasons are actually, you know, those that, you know, eligibility or not don't factor in because they're no longer here. So that's just some of the initial analysis we've done. I know that us and DSS are both working on some churn information as well. You know, we're just tracking because of the renewals, you know, procedurals being a 3-month period. It's kind of hard to put that out before the first cohort has even seen their 3-month reconsideration period. So that's something we're looking at as well.
So you mentioned a little bit about aging out as one of the potential reasons for that explains some of it. Are we seeing that a lot of the big chunk of the people who that they are at that age? Because I just always remember us having trouble keeping a big enrollment in, you know, teenage years. So I'm just, you know.
I think when I last looked at the numbers, I don't have that exact. I think it's 9 or 10% were already over the age of 19 out of everyone we knew we would have to touch. Now, again, ex parte, we say where people can move. And so it is possible that a 19-year-old could find themselves in expansion through ex parte. So that's not something where it just cuts off. And I think one of the reasons also they're staying on longer is, of course, prior to unwinding, we were automatically cutting off coverage as an age out. We know that was incorrect. We fixed it way before unwinding started. So now we're also seeing some of those, you know, it's kind of shifting the reasons, whereas maybe before they were cut off, you know, and now they're not turning in the paperwork. But yeah, we're trying to make sure we get the message out there that just because you might not be eligible where you are today doesn't mean that you're ineligible as a whole.
And
But we can definitely break that down a little bit more for the next meeting, once we have a few more months, of course, of data as well.
yeah, and I totally get that transitioning people from Medicaid and CHIP to the marketplace is not always an easy thing. Um, I'm always like, it's not going to work so well. And I think I can't even remember, but I know that there was some numbers like very small compared to how many people are losing coverage right now nationwide. But so the groups that like the aging out group, the over income group, all of those folks is Virginia sending them to the marketplace, doing what you can on your end, knowing that somebody's got to catch them on the other end and help them through. But that's what's
Yeah,
happening.
so basically, if you are determined ineligible and not for a reason such as, you're not eligible for expansion because you have Medicare, because of course Medicare we wouldn't send, or because you moved from the state, because then we didn't actually determine your eligibility, so it's a little nuanced into, and I'm gonna say the FFM, because also remember, space exchange coming too. But we don't send procedural closures because through CMS's FF marketplace eyes, if we didn't determine them ineligible, they can't necessarily determine their eligibility. At least that's what we've been told. So yes, but anyone else that is not on Medicare and is determined ineligible does get that referral. And that's actually part of some of the outreach that occurs with the health plans, actually. They're given closures not only for procedural, but non-procedural. We do require procedural outreach, just so they say, hey, make sure you come back. And the health plans are also invested in that because, of course, if we get them re-enrolled within that 60 days, then they get placed back in the health plan where they were. So it's a really good, actually, relationship to have that outreach with them.
Actually, a question I have, if you had data comparing the various health plans to see, how they were all doing, are they fairly comparable in their ability to have engagement with their members and make sure that they understand about turning in their paperwork?
So we do require them to give us a monthly report with their information. I have myself not seen those, and of course with the procedural outreach, it's kind of the same thing. It's seeing how those cohorts are going through their 3-month process. Again, something we could think about bringing, perhaps to the next meeting to look at that. But
I've seen the data.
There we go.
And I looked at the data. All of the plans are actually doing multiple touches throughout the process. So it's, before someone hasn't completed their procedural, their renewal, end up getting closed procedurally, they are receiving anywhere from 2 to 4 outreaches from the health plan trying to get them to, and then after that, still getting that outreach. And then we have a couple of, and this was a really hard line to draw, but we had to basically research. So we have a couple of high risk groups that we actually have a live person calling and care coordinators working with the individuals that they need assistance, and we're doing a few different efforts for those that are registered with the Department of Bond and Visually Impaired. So we have a few, they get like an additional layer of even more outreach within certain populations.
And then I had another addition to what Shelby said, and it's probably a small percentage, but I was thinking about college age kids who may not be 19 yet, but if they go out of state, they probably wouldn't be covered with Virginia Medicaid. And so they might have to take on the school's health insurance in order to be covered in a different state. So that may be a small piece of the puzzle, but just another question, not at 19, but even starting a little bit lower, 17, 18, up to 21, 22.
And of course, the rules with the college kids are always a little bit tricky too because of residence, because you can't consider the dorm a permanent residence. So, in terms of covering them, but yeah, it could be the same thing. The parent gets the packet and thinks, my child's in college in North Carolina. They're not in Virginia anymore. Yeah, it's the unfortunate part where it's like we have that first page that's like, do all these things, fill it out, call here with questions. But we try as best as we can to say, the most important thing is turning it in. I think a lot of people think also they'll get in trouble because they've kept the coverage, and we've been trying really hard to say no. not gonna go after you. You were protected. Yeah, this is why we did this. Keep protected.
A quick question just about processing renewals. Are things running relatively on track in terms of processing times, or are we looking at some backlogs still? I know I think I heard Sarah maybe shared at a meeting a while back that there were backlogs.
There are backlogs. Actually, I might be a better person to answer that question as to what they're at, because I'm not positive where they are right now. I don't know if they are. But I know the locals are struggling. Keep in mind, 4 months, almost 40%. So they're doing an amazing job. But I know we do have some localities that really are struggling a little bit.
Yeah, we definitely have localities that are struggling. I can get you some numbers if you want exact, figures. We keep track of that on a weekly basis of our backlog, but we definitely have agencies that are doing a little bit better than some. And we have actually developed a state level processing team that goes in and we just pinch hit where we can. I'm not going to probably get into the level of detail here, but we're helping. We have data that we use to determine where we want to place our efforts. We're really placing some deep and heavy efforts right now with Richmond City because they're really struggling with vacancies and other things like that. And you may have read about some of that in the news recently, some of the things that they're struggling with. But we have a processing team of close to 30 people that are working to help get these backlogs down. And they're experienced, they're not just, run of the mill folks, they're experienced people. And we have a support plan that we have created that also, and we've submitted that over to the eligibility and enrollment division, and we're, expecting any day that CMS may want to see it as well. I don't know, but um, you know, we have efforts in place that are historic that the regional staff and the state staff have engaged in just, over the years. But we have some other things that we're trying to be innovative about. We're trying to look at the agencies that are doing well and say, hey, can we model the efforts that you have in place, and can we, use these? Is it feasible to use what you're doing in this agency in another capacity? And so we're trying to really just we're going out. As a matter of fact, there's a on-site visit today that I couldn't be at with Shenandoah, but we're going out. We're not just having virtual visits. We're not just making calls or sending emails. And we're not approaching it as like a I got you or a sneak attack. It's like this is an all-out effort excuse me, to improve, for process improvement, to use what people have in place. We start the conversations off with, what are you doing? What are you doing well? What are the strategies that you have? What are the things that are helping to move the work forward? Okay. And what are the barriers? What are the barriers to that? How can the state help you? How can we use the resources that we have to, again, move the work forward? And then what is the plan, and what is that going to look like 30 days from now, 60 days from now? And we're following up, and we're corralling all this data together, and we're providing it in a written format so that people can see that we're not just talking about getting the work done, we're actually putting intentional effort behind it. And so but I can look to see if I have the exact numbers. But yeah, there are some backlogs, of course, but we are putting efforts in place with, keys to hand to the keyboard and pen to paper, but also I think Jessica and Sarah talked about system enhancements, working feverishly to make sure that our systems are in alignment with what federal requirements, mandate that we have as it pertains to the work that we need to do. And we also always keep in mind keeping limits on the manual work for the local agencies. They are overtaxed and they are struggling. And so with those system enhancements, we always want to keep in mind less taxing work for the local agencies. So it's definitely an all hands on deck effort right now. And that's where we are. But I'll see if I can find the numbers if you really want to know, like line by line, what the backlog looks like. But there's definitely one, but it's getting better, I would say.
With that, just based on time, I do think we have to move on to the next section. So
So we actually have a new DMAS staff member that we wanted to just introduce and give her the floor for a minute, and it's a familiar face. Rebecca Anderson is our new maternal child health manager. And I just wanted to give her the floor for a minute to say a few words about herself and her role and the role of her division, her unit.
Thank you, Hope. Yes, I see some familiar faces. Rebecca Anderson. I was formerly with DMAS within the policy division and then subsequently the program operations division. And you all know me from previous conversations we've had about school-based services. That was one of my priority projects in the past. I took a little time off, lucky me, but I actually missed this place, missed the work, missed the people. So I'm back in a new role. I'm the manager of the maternal child health unit. That's a division or a unit that works out of our healthcare services division. My primary sort of purpose in work life is really going to be about bringing all the disparate activities that are going on around children and health, the activities that you all hear about. At your meetings and trying to do whatever I can to see those things are aligned. I have a particular priority to be working with data and getting data better aligned as much as possible for all of our various reporting requirements. We do a lot of work, of course, directly with the MCOs, oversight, as well as support and relationship building with our MCOs. And other key stakeholders, most notably the Virginia Department of Health comes to mind there. So lots will be going on in that space. So yeah, I'll be looking forward to returning to CHIPAC. And I don't have anything more specific to say at this point, other than I'm glad to be here and among y'all again.
All right. I am Christine Minnick. It's good to be here today. I'm the Child Welfare Program Specialist here at DMAS in the Healthcare Services Division and the Maternal and Child Health Unit with Rebecca. And I will try to stick to my notes today because I'm known to ramble and I know that we are, short on time. So just wanted to share a little bit of a brief update today because last month we wrapped up a 2-year quality improvement project with CMS that was focused on improving timely healthcare services for youth and foster care in Virginia. So we can go to that. Yep. So just a little background on this member population. According to Virginia Administrative Code, foster care is defined as 24-hour substitute care for children placed away from their parents or guardians for whom the Title IV agency has placement and care responsibility. Children in foster care placement are eligible for Medicaid unless they are not considered Virginia residents or they have income or other financial resources that make them ineligible. So for eligibility and identification purposes, children in foster care are assigned to the aid category 076, and this is how DMAS and the MCOs know that the child is in foster care. And according to DMAS enrollment data as of August of this year, there are 6,136 children enrolled in Medicaid through foster care, with approximately 95% at any given time enrolled in managed care. So children in foster care have higher rates of physical and behavioral health care needs compared with children without a history of foster care involvement. They also use more of certain categories of healthcare services than the non-foster care population, and some of those include hospitalizations for perinatal complications, infectious diseases, and mental health disorders. So because of the complex healthcare needs of this population, it's crucial for children in foster care and entering foster care to receive timely initial medical health assessments in order to be connected to services to meet their needs. Virginia DSS foster care regulations and Virginia Administrative Code state that the service worker shall ensure that the child receives a medical examination no later than 30 days after initial placement. So on this slide, we are going to go over this affinity group that we participated in. So one part of my role in supporting foster care members over the last 2 years here has been co-leading the Virginia team along with Laura Smith Hughes, who's the foster care program manager at the Virginia Department of Social Services, in a quality improvement affinity group hosted by the Centers for Medicare and Medicaid Services. And a brief background on the project: the CMS QI Technical Assistance Program supports Medicaid and CHIP programs and their QI partners with information, tools, and expert knowledge to improve care and outcomes for Medicaid and CHIP beneficiaries. And our foster care affinity group took place from July of 2021 until July of this year and sought to drive measurable improvement in the completion of comprehensive health assessments within state guidelines among children newly enrolled in foster care. So through the affinity group, DMAS, DSS, and our health plans had the opportunity to really expand our understanding of data-driven interventions and improve timely access to care while also learning about quality improvement using small tests of change. So we want to just share a bit about our process of developing these pilot tests and a small sample of the outcome data we collected throughout the project. And as you can see on this slide, the Virginia team's aim statement or goal was that by December 2023, we would increase the rate of children entering foster care who receive an initial medical exam within 30 days. On the next slide, we have some intervention and improvement strategies that we developed. So in order to develop these intervention and improvement strategies, we engaged our system experts and stakeholders to gather baseline data and to map out the general steps in the transfer of information when a child enters foster care. So DMAS hosts a statewide stakeholder group called the Foster Care Partnership, and we were able to use some of those meetings to develop a timeline of steps from a child entering foster care to their assigned MCO being notified and the MCO being able to outreach to initiate services for the youth. So without getting too far into the weeds, one of the first things we discovered and we started learning was that close to 3/4 of the youth entering foster care that we were seeing were already enrolled in Medicaid and an MCO, just in another eligibility category. So because of this, and because we wanted to leverage MCO care coordination as part of our improvement strategy, we decided to focus this project only on that 75-ish% of youth who were enrolled in Medicaid and in an MCO already when they entered foster care. So this is the mapping process on the screen, just kind of a brief map that we put together for those children entering foster care without going through that initial fee-for-service period for new enrollees. So these are youth that are already enrolled in MCOs when they enter foster care, which is the majority. So the steps involve local DSS foster care worker, local DSS eligibility workers, and then of course the transfer of data between our systems. And then we've got our one-time a month process of changing the eligibility for members, and then the sorry, I lost my place. The DMAS system processes the enrollment changes one time per month for the upcoming month of eligibility. So then the MCOs receive their enrollment report. So at that time, there's potentially up to 90 to 100 days after youth enters foster care that the MCO can be officially aware of their members being in foster care. On top of this, we also learned that the systems don't actually share the date of custody. So our main conclusion as we were developing some hypotheses and test ideas was that because of the way the system is currently set up, the foster care enrollment and MCO outreach is often occurring too late and without all the information needed to be able to make an impact on those first 30 days of custody, which was our goal. So we knew our first area of focus would need to be timely notification of the assigned MCO when a youth enters foster care for this project. So on the next slide, we've got a couple of the change ideas that we came up with. We had several kind of pilot tests, but just want to highlight one or two today. So together with our MCO partners on the team, we developed several pilot tests, identifying process and outcome measures and tracking data over time. Our hypothesis being that if the MCO is notified sooner, then a care coordinator would be able to reach out and assist with scheduling a medical exam within those first 30 days of a youth entering custody. So two of our tests were different variations of warm handoffs of foster care member information to avoid that delay in the system. So for the first test, we worked with one of our DSS localities involved in our foster care partnership, Bedford County. They worked They were very gracious in sharing their intake process with the group so that we could learn, and their intake process actually already involved a secure email handoff of that information to CSA and to, between the foster care unit and the benefits or the eligibility unit that the member has entered foster care. So we were able to kind of jump in there and get that information on the day of custody for that test. And we also developed another pilot test where Virginia DSS would send a list to us to DMAS twice per month of the Medicaid eligible youth who had entered custody in that 2-week time frame in the state. So for both of those tests, warm handoff tests, DMAS would identify the assigned MCO for those 75-ish% of members that were already enrolled. And if they were already enrolled in the MCO, we would go ahead and notify the MCO that their member has entered foster care, and the MCO would be able to begin that outreach hopefully immediately. That was our plan. So on the next slide, we can look at some of the data from our Bedford test. I know this is hard to see, but our two main process measures for the test was timeliness of MCO notification and timeliness of MCO contact with member. Just to give some context to this data, as of July 2023, there were 75 children in foster care in Bedford, so that's about 1.5% of the state's total youth in foster care. And on this chart, the red line is the number of days from custody to successful MCO outreach to the member. The yellow line is our team's goal of 5 days, and the green line shows the median value. The first set of vertical gray dashes coming up from the week of October 10th, 2022 indicates the date we started this test. And we see the baseline data from before that date ranged from about 40 to about 70 days between date of custody and MCO contact with the member. And then we can see that over time, in the course of several months, the warm handoff test was consistently successful in decreasing the number of days between custody and MCO, successful MCO contact with the member or the foster care worker. And the next slide shows the outcome data for this particular warm handoff test. And this data reflects the percentage on the y-axis of youth in Bedford who received their initial medical exam within 30 days of entering foster care. The red line is the rate of exams completed for new foster care members within 30 days. And both the goal value and median value are 100%, which makes it difficult to see, but those are the yellow and green lines right at the top at that 100% line. So we see, again, fluctuating rates for our baseline months prior to October 2022 with anywhere from 100% compliance down to 25% of youth with timely initial medical exams upon entering foster care. And in January of 2023, we adapted the test further to have the MCOs outreach directly to the foster families when possible to assist with scheduling, since we were finding that they were typically the ones doing the scheduling in the absence of MCO outreach. And since then, we can see on the chart, since January 2023, we have 100% of exams were completed within 30 days in Bedford. So that's exciting initial, small sample of data. And we can go to our next slide with just some reflections. Even though this 2-year project with the technical assistance aspect of it wrapped up last month, we are still kind of analyzing as a team everything, all of our data, everything we've learned, and kind of developing next steps moving forward with this work and what we've learned. A few immediate takeaways that we were discussing as a team are summarized on this slide. We really believe that a crucial learning moment was when we mapped that process flow and involved all of the agencies that kind of touched the process with the local DSS agencies, DMAS, and also the MCOs. And it really helped us realize the extent that the timeliness of Medicaid enrollment and MCO notification and outreach was a barrier to making improvement in the first 30 days. So we believe that our work in the affinity group enhanced coordination and collaboration among our agencies and removed information silos and allowed MCOs to collaborate directly with local DSS agencies around a common member goal. And then our next slide is just our next steps. The Virginia team plans to continue to work together to explore ideas for and evaluate the importance of reducing the MCO notification and outreach time. And we plan to utilize our interagency work groups, as briefly mentioned, through our foster care partnership to continue this quality improvement work together. So we also plan to continue to utilize the tools that were provided through this affinity group, the quality improvement tools, to work towards timely medical services, ultimately for children in foster care. And the next slide just has my contact or our contact information for our foster care program inbox. We're always open to ideas, suggestions, questions, concerns related to anything discussed today, but also just anything involving members in the child welfare system in Virginia. So please feel free to reach out anytime. And I'm happy to take questions if we have time.
I have one question if no one else does. Will you or are you looking at the 25% of children who are not enrolled in Medicaid when they come into foster care? Because I know there can be some significant delays in getting an MCO enrollment even after the application is processed and approved.
Yes, we definitely are interested in that. I think for this project, it was just hard to kind of have both tracks in mind with our MCOs on the team and willing to kind of help engage in that quality improvement process. We just focused on that, but we are kind of, this has made us aware of a lot of, the delays just with the current way the system processes for both fee for service and MCO members. So we're definitely looking at that.
Great. Well, if no one else has any questions, we can move on to a topic our committee has talked a lot about, school health service expansion. The waiver was submitted 3 years? SPA was submitted 3 years ago to expand school health services. And so we're just going to do, I think, a relatively quick update on that.
Yes, I am going to keep it brief in hopes that we will have a more substantive update, and I can hopefully at that time be joined by our DOE folks, Amy Edwards, to announce some bigger news. But today I'm just going to give a short status update because I know that there is so much interest in this issue and the committee has had an abiding interest in it. And we do have a new staff member that I wanted to introduce, Lynn Hamner, and please feel free to come sit at the table, Lynn, who's in our program operations division. She is going to be our new school services lead, and she's going to be leading us and working with the schools on implementation of the expansion of Medicaid reimbursement of school services. So we are thrilled to have her on board and looking forward to working with her. And I'm sure she'll be with us if we give another update in December or March to the committee. But I just wanted to kind of give an update on where things stand. And because this can be I think a somewhat confusing thing to explain, I did want to kind of do like a little bit of a reintroduction to what it is. I know we've had some new members join the committee since the last time that we did an update. This is actually going to look a little bit familiar because I stole Rebecca and Amy's slides from last time with the explainer. But yeah, I wanted to kind of at least give the overview for those of you who did not hear this at last year's presentation, just so that you know what exactly it is that we're talking about when we talk about Medicaid school-based services. So the main thing I think that is important to understand is that the Medicaid school-based services program, what we mean when we say that, it's a reimbursement program for services that the schools, the local education agencies or school divisions are already providing that are Medicaid reimbursable services. And these are services that they are required under federal education law to provide as part of a free and appropriate public education. So they're providing the services, and really DMAS's role is to facilitate the pass through of federal reimbursement, federal Medicaid dollars that the local divisions are putting up the state match for in the form of their expenditures in the staff and the contractors that primarily staff, but also contractors that provide these services in the schools. So the school divisions, the schools bill Medicaid, they take part in a cost-based reimbursement process, and DMAS facilitates some of the aspects, the components of that. And of course, we receive the bills and we pass through the federal funds. Next slide, please. Can we go? Yeah. So this illustration, which I can't take credit for, is I think a really good walkthrough. Uh-oh. Can you advance one more slide? Because I think the words aren't showing up. Oh yeah, it's like an animation. Sorry. The first piece of this is the local school divisions are spending money providing student health services. Their Medicaid reimbursable services that are rendered by school employees and contractors that are Medicaid qualifying providers. So the salaries and benefits of those providers are the first piece of the formula. And then the second piece is that we conduct a random moment time study that samples moments of time spent by those participating school providers. And we use that to get the percentage of staff time spent directly with students providing services. And then the third piece is that we look at the proportion of students who are enrolled in Medicaid and FAMUS in the schools. And that all of those factors together get us to the reimbursable expenditures. Next slide, please. And then I think we can go one more. So what is going to change right now? DMAS only reimburses schools for the portion of the services that are in the individualized education program, the IEP. So primarily that's our special ed children who have an IEP. It's reimbursing for the Medicaid services provided to Medicaid students with an IEP. And if you go to the next slide, yeah, so during the 2021 General Assembly session, legislation passed that directed DMAS to seek authority using a new federal pathway that allows us to also pass through that federal Medicaid reimbursement for services outside of the IEP. So that allows us to reimburse for services to Medicaid students who don't have an IEP. And for Medicaid students who have an IEP, it allows us to reimburse for services outside that IEP. So really kind of grows the pool of reimbursable services considerably. So we did submit the state plan amendment later that year, and we've been working with CMS since then. And when we get approval of that SPA, that will mean that we will be able to reimburse for any Medicaid reimbursable service that's provided in school that's in our state plan. And just to kind of give a sense of the potential scale of that change, we had 50,000 students with an IEP who were Medicaid FAMUS students that the LEAs were reimbursed for, the local education agencies were reimbursed for with Medicaid dollars in fiscal year 22. But there are more than 800,000 children enrolled right now in Medicaid and FAMUS, not all of them school aged, but many of them school aged and enrolled in public school. And so potentially any of those students that are receiving services in the schools, those services could be reimbursable in the future. One more slide. So, and then some additional changes that the SPA makes are that it adds some new provider types. And in the behavioral health space, that's licensed school counselors, substance use treatment practitioners, licensed behavior analysts, and assistant behavior analysts under the supervision of LBAs. And then it will also add some new services, namely ABA and substance use treatment services that can be included in the cost-based reimbursement formula. So as a status update on the status of the SPA, we wanted to be able to tell you all today that the SPA was approved, but it is not approved yet. We think we are very close, very close. And so we're hoping like early on in the school year, we will secure the approval of the SPA and then become able to focus our efforts on getting the word out, providing technical assistance to the schools, working with our partners at DOE and the school divisions to make sure that all the school divisions that can participate in the cost-based reimbursement do so, and that they do so for as many services and providers as they can so that they can really maximize that federal reimbursement. So that's going to be our focus moving ahead in the new school year. We are also working to digest, there's new federal guidance out from CMS, that really a massive amount of new guidance on Medicaid funded school services, massive 200-page new billing guide, or I forget what they're calling it, like the mega guide or something. They have a word for it. But so we're just kind of pouring through that and getting a handle on, because it does provide some new opportunities for streamlining things, making things administratively more simplified and easier for school districts to actually be able to participate, because it is kind of a learning curve. It involves actually doing billing and participating in a time study that can be a little bit confusing, and you have to train your staff to be able to answer the moments when they get a ping to do so. And then there are also some new compliance requirements that are outlined in that new guidance that need to be in place by the end of fiscal year 26. So we're working on getting a handle on all of those and kind of exploring opportunities as well as new requirements we need to get in place. So hoping to have additional progress reports for you very soon, and letting you know a little bit more about implementation as we really get into the thick of that. But that is where things stand right now. And if you have questions, please feel free to email myself or Lynn. I think that's all I have for now, but happy to answer questions if there are any.
I have a question.
Yeah.
Sorry, Hope.
Yeah.
We've talked
You
about
can
this
apologize.
before, but with the amount of folks we have in managed care in the state, the plans are also serving these kids.
Yes.
And we think it's great that they're getting services in schools, but we want to make sure we're cutting down on duplication. There's some coordination so that, the plans are able to get folks the things they need outside of school, but then also we're not duplicating.
Yeah.
Especially for some of these higher end services like ABA and things like that. So I know that's an implementation question, but it's an important one.
It is, yes. Yeah. And we do want to continue to work with the plans. We have to be mindful that under federal law, and this is Medicaid law, we can't restrict services outside of school based on the services that Medicaid is reimbursing in the schools. So as we think about, care coordination is important, and it's important to be able to see the full picture of the services the students is receiving, but we can't limit the services in any way. So we have to be mindful of that and just keeping on the right side of that.
What's going on with the kids who are covered under a 504 plan but don't have an IEP?
Currently,
yeah.
I believe that there's a mechanism for them to receive, for the schools to receive Medicaid reimbursement for them already, but there certainly will be after the SPA is approved. After the SPA is approved, instead of the IEP kind of being the plan of care that authorizes the medical services, there will be a plan of care that's just signed by a provider that authorizes those services and that they're medically necessary. And that would include a 504 plan.
I was just curious, since this is based on the number of students with an IEP, but there are probably a significant portion of students that are receiving services without that. How do you, to maximize the reimbursement to the schools for services? It's just what
I'm not sure if I understand the question, but it is going to expand considerably when we.
Right, but
yeah.
So I guess the thing that I have doesn't make sense to me is if it's just based on the number of kids, or has been based on the number of kids who have IEPs, but
it's not so much based on the number of kids that have IEPs as it's that random moment time study. And so the IEP services were the only reimbursable services before. And so when a provider answered that random moment, they would have to select an answer that said that they were focusing on a Medicaid reimbursable IEP service at the time that they got so it's sort of the way that it's calculated.
So is
The
IEP coming out of the conversation?
the
Just the services being
the
offered?
IEP
correct.
restriction also was it's a federal restriction under the free care rule that was like a long-standing Medicaid rule that has recently been changed in light of like some federal law that said we have to be doing this in a better way, and that's why CMS put out this 200-page guidance. And so the restriction was not a Virginia choice previously. It was like the federal rule said it had to be a service that was a Medicaid service that was provided to a Medicaid child who was enrolled in the IEP, and like the IEP service and all that was coming straight from CMS. But now we get to
They don't have to have an IEP to still receive the service and schools get reimbursed.
They do. Currently, in the way that it's currently implemented, for the most part, the student has to have an IEP. And it does factor into the school's reimbursement. You're absolutely right. If we get the SPA approved, that requirement changes. And it gets very complicated, and I won't get into all of that, but it will still impact reimbursement. The proportion of students that are enrolled with an IEP, 504 is not part of that. It's still special ed IEP. But like I said, when we get going, we may want to bring in some financial experts to talk about the formulas used, but so it's still a factor, but it won't be the same as it is now. It does broaden their opportunities.
Thank you.
And I have one more question, sorry, and then I'll move on to public comment if anyone, if no one else is. The services you kind of listed were all kind of medical services, but the federal guidelines are really broad in terms of reimbursement for administrative things as well, like enrollment and eligibility. And are we restricting that in our SPA, or are we still going to be able to?
I want to
pursue
be
that?
really clear that what I concentrated on today was the direct services piece of the puzzle. So there is there's also an administrative reimbursement piece of it. And there may be some, I don't have as firm a grasp on the changes to that if there are significant ones, but I don't think there are any major ones, but there are new flexibilities under the federal guidance in that area that we could potentially take advantage of.
It is 1 minute to 3, so I'll give a quick kind of 30 seconds. If anyone has any additional items that they would like to add to the agenda for the executive subcommittee to consider for the agenda for December, let me know. Put it out there now, or obviously you can always email us. The subcommittee meeting is October 13th again, so just let folks know before that if there are things you really want covered at that meeting, potentially school health services, if we have kind of good news and more robust guidance available. And if not in the moment, then just are there public comments? I don't know if anyone is online still.
I'm gonna check and see if
There's LeVar Bowers has asked a question
in the chat
about
how would school-based services impact capitation rates? To just, so they're a fee-for-service carve-out. So the school-based services that I'm talking about, that I just presented about, that definition of school-based services, it won't impact the capitation rates. There are services that kids receive in schools that the managed care organizations provide, and those, those are not at this moment in time changing under this new policy. So there would be no impact there.
Great. With that, thank you all so much for coming today, and have a great rest of your day and a great weekend. Thank you, everyone.
Right on time. The recorder. I don't know if I can say it.
Refrigerator of minute. Just a tad hard. Sorry about that. You're gonna brought you up to the table sooner.
Step in and rescue me there. I forgot, how my second email, but then I was like, okay. Yeah,